Test, test. Ladies and gentlemen, including Gianluca, good morning, and depending on where you are viewing this online, good morning, good afternoon, good evening, and welcome to the briefing for the 77th World Health Assembly. I would like first to start by thanking each and every one of you for making time to physically come here to Geneva, and for those who are joining us online for logging in. My name is Ahmed Ogwel Ouma, Vice President for Global Health Strategy at the UN Foundation, and it is really my honor and pleasure to be joining you this morning for this briefing. Secondly I would like to thank our co-hosts, the Global Health Center here at the Geneva Graduate Institute, for being a dependable partner when it comes to the work that we do, especially for this briefing. And I would like us to put our hands together for the women and men who have put this briefing together. This is the 10th anniversary, so a very, very significant moment. And we'll be here for the 20th anniversary, and I hope each and every one of you will find time to be here physically and not online for the 20th. So thank you very much for these 10 years of organizing this briefing. Our briefing this year has the quite relevant theme of addressing health challenges in an increasingly polarized world. And this is particularly poignant because we have negotiations that affect health one way or the other, global health particularly, that have been ongoing for quite a while. We are in the margins of the COVID-19 pandemic. Although many of us would like to forget, it did happen. It's still affecting us to date. And really, the polarization of the world is a challenge that we need to engage with and give the necessary ventilation so that we can achieve solutions that are going to be relevant if anything does visit the shores of Earth anytime soon. So the theme this year is very, very relevant to what is happening around the world. We are going to have a very interesting briefing today, and I am hoping that we will not only engage with the sessions where we can be able to ask our questions and make our comments, but I hope that we will be taking away messages from each and every one of those sessions. I'll not go through them. You're here. You will listen to a very, very one, experienced panel, second, educated panel, and third, a very relevant panel to the theme that we have this year. So I ask you to engage at the appropriate time so that we can be able to get the benefit of the experience and the knowledge of those who will be up here on the podium sharing with us the different segments of the agenda today. Having said that, I would like to really remind first myself and then us that during this season of a lot of negotiations, multilateralism has never been more important, because in negotiations it is not that anyone is wrong and others are right. It is that there are interests that we need to bring together on the table, discuss, and then agree on which one is to the benefit of us all in the best possible way. This reminds me of a fine, wealthy gentleman, usually it is a man, who decided to secure his mansion from any threats that came from outside. He secured it so well that when the threat came from inside, He didn't have a way of getting out quickly. Neither did he have a way of being helped from outside because he had secured himself so very well. This is where we are today when it comes to multilateral platforms and the negotiations that are going on. Let us not secure our mansions so well that when the threat comes from within, we cannot be able to help ourselves, and neither can our neighbors, friends, and passers-by be able to help us because there'll be no way in. It is time for those of us who are negotiating to ensure that we are doing it for the benefit of us all and not only ourselves. Then I would really like to thank our panelists and speakers who have accepted to grace the briefing today. I'll introduce them as we go along so that we can be able to catch up on time, and really appreciate those who have joined online, and we hope that they too can be able to benefit from the beautiful atmosphere that is here in this auditorium today. So I would really like to start by inviting my good friend. He's looking younger and younger every other time that we meet. Gianluca Bucci, to come and really flag for us some of the key things that we need to be reflecting on as we get into the 77th World Health Assembly. Gianluca.
Good morning, and as usual, good evening, good afternoon to people online from hopefully a number of countries. This presentation, can I have this slide? Thank you, is really dedicated in particular to people that are the first health assembly or that maybe didn't get involved enough and they think that the health assembly is a week of total chaos and confusion and so on, which it is. But there is order in chaos. And so what I would like to do is to give you a sense of how the assembly is working, really the nuts and bolts, and maybe just a couple of hints about things on the agenda or that will be discussed, and some of the, as Ahmed said, or the politics that inevitably comes and creeps into the health assembly. So first of all, this is how the plenary hall looks. But as you may know, the Palais des Nations is under renovation. And so the spaces have shrunk a little bit. The assembly hall is under renovation itself. So meetings are taking place in a smaller number of rooms. In particular, I understand the plenary may take place in this beautiful room, which is a room of the Human Rights Council. But obviously that has an impact also on the possibility of participation from the public and so on, because just there is limited space. So what I would like to do today is these four things, just to give you an idea how the assembly works, who participates, how the work is done, how decisions are taken, because the assembly is not just there to discuss, it's to take decisions, resolutions, and so on. And finally, an idea of what is on the agenda or what can the discussions be about. So first of all, who participates? Obviously, the people in the main driving seat are member states. WHO has 194 member states. I don't think we all have all 194 in the room, but you appreciate that some of the member states, for example, the Pacific Island states, they take 2 days of flights to come to Geneva, and they do come. So that reflects the importance that many, many countries, in particular small countries, give to the Health Assembly as a moment when they can have the voice heard and they can also participate in a big multilateral debate. Besides member states, obviously, there's quite a number of other participants. And immediate partners are international organizations, starting from the United Nations, specialized agencies. Actually, on the agenda this year, there is the conclusion of an agreement with the OECD, the Organization of Economic Cooperation and Development. And on that basis, then there is a mutual invitation to participate in each other's meetings. So for next year, we could have also the OECD participating formally in the Health Assembly. Then you can see, I will not spend too much time, there are 2 observers invited by the Health Assembly Palestine and the Holy See. Other observers are invited by the Director General, the Global Fund, one of the important partners of WHO. And then public and the media. That's obviously very important. This is not just a purely cloak and dagger intergovernmental meetings. Again, the participation is a bit limited by the lack of space, but the web streaming, I think, has democratized quite a lot the possibility to at least listen in what is being discussed. Obviously, very important are non-state actors. And we go by this FENSA, that the acronym for this framework of engagement was adopted in 2016, that has in a way, regulated and rationalized the participation of non-state actors. So the three categories that you see on the screen, NGOs, international business associations, and philanthropic foundations, they are admitted by the executive board, and they can participate formally in the Health Assembly. The participation largely consists of making statements after member states. There has been a certain impatience by non-state actors. We can only speak at the end for 2 minutes, 10 minutes before the end of the meeting. People are looking at the watch. It's not very meaningful. So there has been an attempt to integrate non-state actors more in the intergovernmental negotiation. But in my perception, one of the main interest of non-state actors is to be physically in the room, because you can lobby delegation, you can make connection, you meet with your partners, you strike alliances, and so on. And so, in a way, COVID was a shock for multilateral diplomacy, but I think it was a disaster for non-state actors, because for 2 years they lost access physically to what was happening in Geneva. So it's very good that hopefully that phase is over. So how does the WHA work? And at least there is a bit of order in the chaos. The WHA is the shortest governing body of the UN system. It lasts little more than a week compared to the opposite extreme, the General Assembly of the UN, which is in session 12 months. So everything has to be transacted and decided in the short period of time. It can be confusing. Items can move between committees. So the Secretariat some years ago started what we call a WHA app, which can be used by people that are accredited to participate in the Assembly, and it gives you in real time where things are being discussed. It seems banal, but when you are a small delegation, it's crucial to understand where the item that you came here for will be discussed, and you don't waste time or risk missing that discussion. As you know, there is a president. The outgoing president is the Minister of Health of Malta. The incoming president is the Minister of Health of Botswana. And then there are obviously 5 vice presidents, officers of the main committees, all following a fairly codified system of geographical representation that has been quite very rooted in the nature of WHO. So how does the Assembly work? Again, it seems like everything is happening in a bit of a confusion, but the work of the Assembly is broken down in various meetings. Obviously, the plenary is the ultimate decision-making body, but it normally has a housekeeping role, elects the members of the executive board, has a general debate, and adopts the final resolution. So most of the substantive work is transacted in Committee A and Committee B. Those of you who participated in previous assembly know them very well. And items can shift between the committees, because Committee A normally is much busier than Committee B, but this is the main breakdown of the work of the Assembly. Very important also, the General Committee, that's like a bureau of the Health Assembly. It sort of makes the final recommendation on the agenda and sort of tries to steer the work during the Assembly. It meets normally on Monday, on Wednesday, so the Credentials Committee also, that looks at the credentials of delegates, normally sort of an administrative task, but where there are political issues, it can become also a moment of political tension. So we have a long history in the United Nations, and sometimes it happens also in WHO. One of the decisions of the Health Assembly long time ago, there can only be 2 parallel formal meetings. Try not to penalize small delegations, but at the same time, There are drafting committees, working groups, informal meetings, so there's a proliferation of meetings of various types that obviously put a bit of a strain on the resources and the possibility of participation of small delegation. And finally, and your presence here testifies it, the Health Assembly is Global Health Week. There's so many things happening also around the Health Assembly, in hotels, in conference rooms, all around Geneva. It's really the global health community converges upon Geneva, and that's very important because it goes beyond just the formality of the Health Assembly. So as I said, the main purpose of the Health Assembly, besides having everybody meet and giving the possibility of many meetings, also informal and discussing, is taking decisions. So decisions, first of all, to avoid surprises. Draft resolutions can only be introduced until tomorrow. Because in the past there were decisions introduced on Wednesday evening and sort of affecting the program of work and so on. The resolutions are often negotiated months in advance, very much in Geneva. Permanent missions are very engaged. For example, there's a draft resolution on climate change and health that has been led by Netherlands and Peru. So there's a lot of work going on even before the Assembly opens. Then the discussion takes place in the main committees, but you often have drafting groups that sometimes meet even throughout the night when something is very controversial, very important, needs to be decided at this assembly. So you really have all-nighters in a meeting room at the Palais. But sometimes even at the coffee shop, you see people clustering around and they're really discussing very informally something that can then save time in the main committees. The draft resolutions and decisions are adopted in the committees, brought to the plenary, and the plenary has a final adoption. So there are several stages that sometimes can be a bit confusing, but that's in a way the normal procedure of a parliamentary body like the Health Assembly. WHO, like other UN agencies, is very much based on consensus. Having a vote is a defeat, in a way. And so, in particular, on technical items, there is every attempt to decide by consensus without taking a formal vote, without forcing states to say yes, no, or abstain. Things have changed a little bit in the last few years for a number of reasons. One of the controversial points in many cases has been gender, that has forced votes and so on. But in a way, the spirit remains very much a spirit of consensus. Formal votes are for elections, obviously, the Director General, the External Auditor, and Palestine. As I'll say in a moment, every year there is an item on health conditions in the occupied Palestinian territory, and there is always a vote for that. WHO, unlike the UN, unlike ILO, does not use electronic vote. Electronic vote, you push a button and the vote can be done in 30 seconds. WHO doesn't do it, so when there is a vote, it can take 40 minutes. And in a short assembly, that's a problem because it really compresses the time. So, final 2 points. What is discussed? Again, you look at the agenda and you wonder, why is the Assembly discussing these points? Where are they coming from? And fundamentally, there are a few categories. New items that normally go through the Executive Board. So the board sort of digest them in January. And sometimes they come with a draft resolution. There are recurring items, for example, antimicrobial resistance, malaria. They were a previous Health Assembly, but the Secretariat is reporting to this Health Assembly. There are items presented directly to the Health Assembly, and there is one on inviting Taiwan as an observer. Has been an item that has been presented time and time again, and is presented directly to the Health Assembly. And finally, you will see Committee B, there are a long list of progress reports. These are reports without a decision, and they're only discussed in Committee B. In the past, used to be discussed at the board and the Assembly, but that was an unnecessary repetition of the same discussion. But this is not to say that they're not important. Many delegations take the floor because for them they're items of high programmatic importance. Finally, main issues. First of all, technical Governance and politicals. Let's start with the political, that sometimes the more juicy. Obviously, Israel, Palestine, Ukraine, Russia loom large on the agenda. Israel, Palestine, there are 2 or 3 issues. The first, there are 2 reports coming to the Health Assembly. One is a standing item on the health conditions in the Palestinian territory, but there was a special session of the Executive Board in December because of the conflict in Gaza that also has a report coming to the Health Assembly. So it's a bit confusing because there are 2 reports overlapping to a certain extent. The item on Palestine, as I said, is always pretty controversial. Obviously, now will be more than ever, and there is always a roll call vote to adopt a decision or a resolution. The other point is that Israel is a candidate to the Executive Board as part of the European region. And as you can imagine, it's not excluded that there may be an objection to the candidacy of Israel. In that case, what happens? There was the same situation last year with regard to Ukraine. Russia objected to the candidacy of Ukraine. There had to be a vote by secret ballot. So obviously, the Secretariat is ready, but this is a moment of tension, moment in which things are to be conducted very rigorously from a procedural point of view. Russia-Ukraine, same thing. There is an item coming to the Health Assembly on that conflict. Last year, there was a draft resolution presented by Ukraine and the competing one presented by Russia. So there were 2 votes. The Russian proposal was defeated. The Ukrainian proposal was adopted. But again, it takes quite a bit of time. So these are the politics, of course, coming into the Health Assembly. It's inevitable. WHO is an organization of states, so it's inevitable that the politics is reflected also in the work. Finally, and that's my speculation, but I hear signs, the General Assembly of the UN on the 10th of May adopted a resolution giving Palestine, the state of Palestine as it is called in the UN, basically all the rights of member states, except the right to vote and the right to present candidates. For the rest, they're treated like a member state. So there are rumors that the same resolution could be presented to the Health Assembly. It's not the first time, and we'll see if it happens, how is this discussed, and how it can be adopted. On the programmatic side, and I will not say much because the panelists after me will go in details on this, we have the new General Program of Work, 2025-2028. We have the WHO investment round. WHO is preparing for a meeting in November to rationalize and make it more strategic, gathering resources, voluntary resources from donors. It's a big exercise, very complex, involving all 3 levels of the organization. And finally, there is a decision on the process for allegations against the Director General. That comes of a recommendation of the Joint Inspection Unit that all agencies of the UN should have a process in case there are allegations of misconduct against the executive head. I invite you to look at the document. It's long. It's a very complex process, obviously, because of the gravity of allegations against the executive head. I think it's a fairly elaborate and, in my view, balanced process. So you may want to look at that. Finally, technical and programmatic. I'm not a public health person, so as I look at the agenda, I'm not always able to see what is routine, what is not. But there is a long item on antimicrobial resistance with a number of strategic priorities and operational priorities for WHO and for member states. And equally, there is an important item on malaria because of the loss of momentum, also because of COVID or decrease in vaccination and so on, how to basically pick up momentum again towards the elimination of malaria. And last but not least, obviously, we have the reports of the 2 complex and long negotiations on the pandemic agreement and on the amendments to the international health regulations. We are fortunate enough to have Ashley Bloomfield and Precious Mazzoso that will brief us on the substance, but these are obviously 2 very important items that will create a lot of debate at the Health Assembly, in particular, how to go forward and finish the work on these 2 important items. So that's my presentation, and I have 4 minutes according to the marching orders from our organizers. So if there are any questions that I can address, I'll be happy to. I don't see anything online. I don't know if anybody in the room has a question. I know I've been incredibly clear, but you know, human nature being what it is. Otherwise, okay. So I don't see anything online. Then thank you very much for your attention. We are 4 minutes ahead of schedule.
Thank you, Gianluca. Clarity has always been with you, and I'm glad it continues into this briefing today. We are going into our next segment now, and I would like to call upon Pictet Patnaik to come and introduce her panel. That way I speak a little bit less. Pictet?
Hi, everyone. I'm Pictet Patnaik, founder of Geneva Health Files. For those of you who don't read us, we are an investigative journalism initiative, and we track power and politics in global health. It's great to be back at the Institute and also to be moderating this session for the UN Foundation. Our guests today for this session, we have co-chair of the intergovernmental negotiating body set up to establish a pandemic agreement, Precious Matsoso. Please. And steering the amendments to the international health regulations, we have Dr. Ashley Bloomfield. So as a reporter tracking these negotiations, I have really chased the both of you and hassled you over the last many months. Thank you so much for being here and at the end of, or let's say at the beginning of also of a long week. We have lots of questions for you, but really the format is we will go through some of the questions we have, and we'll set aside time for questions from the audience. Please come and sit here. So I think it's on? Okay. So maybe we can start off with, brief introductory remarks from the both of you. Ashley, maybe you can let us know on a brief update of what to expect this week with respect to the amendments package, and what do we expect in the coming days, also ahead potentially of June 1st, where a resolution might be adopted. And as we understand, on Tuesday 29th is when these items will be opened at the Assembly.
Good morning, everyone, and afternoon and evening to colleagues around the globe, some of whom back in my part of the world, Aotearoa, or perhaps in the Pacific, it will be late at night, but hello if you're online. Pretty, just to acknowledge the work that you and your team do, and I haven't felt hassled at all through this period, because this is a really important part of these processes, and the role that you and your colleagues play in ensuring accountability and transparency is really important. So with respect to the working group on IHR, we had a twofold mandate, and the mandate is actually finished, and we've handed back to the World Health Assembly, so we're in the hands of the Assembly. Our mandate was to undertake discussions to agree a package of targeted amendments to the international health regulations, as well as incorporating equity, addressing equity within the regulations, something that hasn't been present explicitly in the regulations. So we've worked hard since November 2022 on that, including many extra sessions over and above what we originally anticipated. And just a week and a half ago, we had our 2 final days of negotiations. The second day went through till 4 in the morning on Saturday, and we then reconvened for another 5 hours and got agreement both there and then in a couple of meetings this last week to submit 2 things to the Assembly for their consideration. First of all, the text that we have been working on, it made clear in there the things we've agreed on in principle, the things we were close to agreement, and the things that require a little more discussion. The important thing here, and this is clear in the report we've put through, is nothing is agreed until everything is agreed. In a sense, it's a package. But the second thing we've put through is a draft resolution, and what we're asking of the Assembly is a mandate to continue the work during this week with a view to trying to complete the package of amendments, and our hope is that it will be adopted by the Assembly before the Assembly is over. So as a Bureau, whilst our mandate has come to a close, and myself and Dr. Abdullah Assiri, my excellent co-chair, have finished our work, we've made ourselves available to continue facilitating that work during the week, if it's the wish of the Assembly after they've considered this on Tuesday.
So more action as the days go by?
Let's hope so, because I think there's a strong intent for us to really seize the moment. We've made enormous progress, and even in the text that's agreed in principle, there are some really significant improvements and significant inclusions that would really help us address equity, which is, you know, fundamental.
Precious, maybe you can give us a brief update on what's potentially going to be considered at the Assembly this week on Tuesday, and how you see this process evolving.
Well, good morning, everybody, and thank you so much for inviting me. And for those online, I wanted to first start by saying why this day is historic, not just for the Assembly. Somebody sent me, and I'll say not somebody, and I'll call him by name because it's in the text. It says, on this day, 12 days ago, Tiru Balu Subramaniam, it says, shared with his friends what South Africa, Precious Matsoso said, recognizing Dr. Viro's leadership. Now, we're adopting, as part of IGWIC, the following. And I felt as I read this, that this is the stage at which we are with regard to INB. It says, all members have been surrogate parents to a baby. And I saw this baby as the pandemic agreement. But at the time, the baby was the CEWG report. It says all members had different opinions on which method will work best. And why I'm saying so is because when I present the options, we'll have to look at which option is best. But again, it says we do not want premature and prolonged labor. But again, you need babysitters and midwives, and foster parents, perhaps, and those who could take good care of the baby when the baby is born. Of course, we do not want to rush, but at the same time, there is need for speed. So there are 4 options at the moment before the Assembly that will be considered, that are being discussed. The first, I think, is similar to what Ashley said, is that of discussing and negotiating whatever is remaining. As you know, we have 34 paragraphs, 34 articles. And of these, 17 are agreed, fully agreed. The other 17 are partially agreed. Okay. And and there's one that is somehow difficult because it's about definitions. And those definitions would have relied on the outcome of the IHR amendments. So why I preface this with the birth of a baby and what happened 12 years ago is because there's the recognition that negotiating during the World Health Assembly, for some delegations, they are needed by their ministers. You can hardly even get them to do anything. So they had said to us, for INB, because it's such an intense process, they would not be supportive of negotiating during the Assembly. So the second option is that of having a resumed World Health Assembly. This means that the World Health Assembly would have to be suspended to reconvene at a later date, but within a specified period. And in that period, the member states would have sufficient time to conclude the work of negotiating the pandemic agreement. The third option is that of having a special session. And this special session would have to be towards the end of the year, like they did when they came up with a decision to come up with a pandemic treaty. So that's the third option. And the last one would be to defer this to the next World Health Assembly, WHA 78. So of all these options, obviously, from what we hear from some member states, is that the first option is not a preferred one. The second, it depends on the timing. If it's immediately after the assembly, it won't be workable because some people are extremely exhausted. The third might be an option, but of course the timing is also important because the geopolitical environment is such that some are concerned about elections, change of administration. It may adversely affect the outcome and the mandates that negotiators have been given.
Thank you. I think with these updates out of the way, it'll be more interesting, to take a step back and try to get a sense of your reflections of the last 2.5 years. Ashley, maybe you can help us understand, what were some of the key moments in the last 2 years where you thought it had a decisive impact on the process? And also, of course, it's not over till it's over, so we can expect a lot to happen between now and Saturday. And maybe you can also, if possible, respond to insulating the track of the IHR negotiations from the INB, although there are linkages and so on. What were some of the challenges you could share a glimpse of how you weathered through all those?
Well, let's put it on the table. The WHA created a rod for its own back by conducting these two processes in parallel. That's my view. And I'm not saying that made it impossible, but it meant that, for our part, Precious may have a different view, but we felt like we were conducting two negotiations in one room, and I'm sure that was the same at times for Precious. And so that was a huge challenge because the two processes had overlapping matters, and it was always going to be challenging to finish one while the other one was still going. It's the chicken and egg scenario. And as I said at our meeting just over a week ago to everyone, it doesn't matter. We don't need to decide whether the chicken or the egg comes first. We just have to make it happen. Let's not worry about that. And the best thing we could do, I felt, for the IHR was to finish that process and support our INB colleagues. However, given that that was the situation we found ourselves in, the way we dealt with that, I think, was really good. We worked hard from early on to meet regularly as bureaus or as co-chairs. We had joint sessions, the first one in July last year, which created a little bit of a division of work to the extent possible, including, as Precious mentioned, that the IHR process took responsibility for the definitions, which we've worked hard on. So the question will be this coming week is, are we able to, if not quarantine or isolate the process of the IHR, at least take the opportunity that is there? And one of the things in our favour, and I will keep emphasising this, is at any point in time we can come back and review and revise the IHR. If we take what is agreed now, the INB process, if it has a mandate to continue, may agree improvements or matters that would be an improvement on the IHR. And we can then make further amendments at any point in time to capture those other matters that might be subsequently agreed. I guess the final point I would like to make is one of the things about these processes is making sure that there's a high degree of trust. And we worked very hard early on. One of the challenges, and I know Precious and Roland have worked hard on this, is getting the Bureau to work as a team. And I think both of us have worked really hard on, in our own ways, of getting the Bureau to be working as a team to build that trust in the process. Because then when you have to push the process firmly or nudge it along as a co-chair, you've got the mandate and the trust to do that. And we've worked very hard on that in the IHR, and my hope is that continues into this coming week, and we can therefore finish it.
So just as a reminder at this point, the IHRs have existed. So in some sense, the IHR track of negotiations had an easier task to an extent while the INB had to start from scratch. So Precious, very briefly on what you thought were some of the most challenging aspects of conducting these negotiations over the last 2 years.
Well, thank you very much.
Yes, it is.
Thank you very much. I think the most challenging has been operating in a complex geopolitical environment. And I've asked the question, if these negotiations happened at the height of COVID, when people were wearing masks, would the results have been different? And I've got a firm belief that certainly they would have been different, because there was a sense of urgency and we're in the middle of a crisis. But now, with complacency creeping in, increasingly people don't see this as a priority anymore, and some still do, some don't. But because of that, it has kind of made people relax a bit. There's no sense of urgency for some. But the other is, we've also seen with like I say, the changing landscape, the geopolitics, some of the complex issues that are happening, conflict and so on, all those issues are creeping back into our discussions. And we've seen that repeatedly, and that has changed actually over the 2 years. We did not see this kind of a pattern. This become quite, you see it actually creep in increasingly on certain topics and on certain issues. But having said that, what has been different, of course, is that, like you said, starting from scratch, you had to solicit inputs from member states about what substantive elements to include in the instrument. And when I look at the data, because we collected those inputs from all member states, none of them said equity was not important. Of the 4 key strategic areas that we identified, they all, almost 90%, 98% said equity is important. They said financing is key. They said strengthening of health systems was important. But they also agreed to strengthening of leadership and governance. So those key strategic pillars were acknowledged as key substantive elements that must be included. But there was also another dimension that we could not talk about those 4 key strategic pillars in isolation, out of context. It had to be within the context of pandemic preparedness, prevention, preparedness, and response. And it is from that context that we had to marry all of that and see whether we could address comprehensively what others saw as important to them.
Just for context as well, the INB was established in December 2021, and then subsequently you had the Russia-Ukraine conflict in early 2022, and in 2023, the Israel-Palestine conflict. So it was a different world when these negotiations started in some sense. And as co-chairs, you have also dealt with, a tsunami of misinformation, forces fighting really in national parliaments. Maybe we would that would be the last question, and then we'll open up for audience questions. The challenges that, how you had to deal not only with the political dynamics inside the room, but also challenges of misinformation, changing governments, politicians turning anti-vaxxers, and so on. Please go on. Ashley.
Yes, this was a challenge, and there was no doubt, it's no doubt in my mind, there was a very well-funded, highly orchestrated, coordinated campaign of misinformation and conspiracy theory generation. Outrageous. I mean, some of them, not outrageous in the sense, well, it was outrageous, but just mind-bogglingly imaginative, some of these ideas that were circulating. And this was designed to undermine both the processes and to undermine the legitimacy and the role of the WHO. And so there's a lot at stake here. This was less of a problem for us in the room, but it was a big problem for all our colleagues negotiating in their own national context, because they were spending a lot of time having to respond to the misinformation that was being disseminated, and those who were undertaking this campaign very cleverly targeting certain politicians in just about every jurisdiction who they thought would be susceptible to picking up that ball and running with it. To quote a rugby analogy from New Zealand, we like our rugby, and then creating, undermining the process, creating dissent, and so that was a real challenge. But I think, if anything, more a problem for those who were negotiating back in their national contexts. Now, we will see something of this here in Geneva on Saturday. I understand there's a coordinated gathering of these people, and the question will be, who's doing the celebrating on Saturday? Will it be those of us who have worked so hard and so assiduously on these processes over the last year and a half, with the intent obligation of improving global health security and addressing equity? Will we be the ones popping the champagne corks, or will it be those who have deliberately set out to undermine the processes who will be celebrating the failure of the multilateral process to actually get agreement on something that could not be more important, so we can break the cycle, as others have called it, of panic and neglect?
Precious, in last remarks.
Well, I mean, I fully agree with what Ashley is saying, and what has been quite disturbing is, what has been projected as some countries going to lose their rights, and WHO usurping power. But I think beyond that is for those who also presented the pandemic agreement as an agreement where supplies are going to be diverted for citizens to be given to others. And governments redirecting priorities from protecting their citizens. So this thing of the misinformation that has been propelled has been quite concerning. It was not just about anti-vaxxers and so on, but it was also about misrepresenting what is intended with this pandemic agreement, and the issues of equity and how prevention is important, and also preparedness, and how financing can be improved, because we know that preparedness was grossly underfunded, and this is one opportunity that would at least have to address that.
Thank you so much. I think we'll have to wrap up. We don't have time for audience questions. Yes, my apologies. We are really running short on time. Thanks so much for showing up, because I know it has been exhausting for the both of you. And good luck for the coming week. And we'll know by Saturday how things go on one of the tracks, surely.
Okay. Yes, and all the best.
Thank you.
Thank you, Preeti, for that, and to the two co-chairs for the two different processes for giving us those thoughts. And Precious, IGWG, it's a while back, but we want to assure you, Bruce, your other co-chairs, and everyone involved at the UN Foundation will always be that very knowledgeable aunt who is always ready to ensure that the process of delivery succeeds. And we will have a bouncing baby girl, hopefully on Saturday or very soon after. Having said that, we move on to the next section, and as usual, Bruce's timing is impeccable. He tells me he's been running after other protesters out there, walking the talk. So I would like to welcome to the podium Bruce Aylward, the Assistant Director General for Universal Health Coverage, and he's going to speak to us today about WHO's 14th General Program of Work. So Bruce, if you step up, you'll have 5 minutes for Q&A at the end of your session, so that we hear from the audience if they have any clarifications they may seek. We've started very well. Gianluca was so precise, everyone understood. Bruce has been running the whole morning. I think the stage is set. Thanks, Bruce.
And now I know what I'm going to talk about. So thank you very much. Folks, sorry if I'm a little out of breath, but it seems a lot of us were in the same event this morning, but you may have walked it. I decided to run it, and then I thought, well, let's run another loop. And then I got myself so soaking wet, I decided I better go home and get a shower, which I did. And then I got soaking wet getting back up this hill. But I just realized that this is a little more informal than I thought. So sorry, with due respect to Lori, to the foundation, can I take my coat off? This coat has to sit through 5 side events today, so it's let's put it over here to start with. So, folks, delighted to have a chance to kick off, and if I might, I'm not kicking off the event. The first discussion we're going to have as part of the run-up to the Assembly on the what we call the General Program of Work, right, which is the most boring title you could give for one of the most exciting documents in the Assembly this year, which, of course, is a new strategy for global health. Have we got the title up there? Right. So what I'm going to do is I'm going to walk you through some of the big elements of this. Many of you will be very familiar because many of you were part of helping to develop this, so thank you very much for that. But what we'll do is we walk through it. I'll just touch on some of the big points, and then we'll have a chance for any questions that you might have afterwards, which Bjorn Kummel or Gianluca or someone else will take on my behalf. You can test their knowledge of the General Program of Work. So as we run through this, let me just start with the title, because this says, frankly, everything that we're trying to achieve in the document. Coming out of the pandemic, the goal really now is a global health agenda for advancing equity on the one hand, with in terms of delivering health services and with our systems can deliver, and also, of course, a more resilient system in the face of what is going to be a much more turbulent world as we move forward. Now, here's the context for our new GPW, or Global Strategy for Global Health. As many of you will be aware, you may not be aware, WHO's current strategy is actually supposed to run through 2025, 2026. But what we have decided is, given the changes in the world, the strategy that we laid out with our 13th General Program of Work, frankly, needs to be updated, needs to be refit for the changing world. And what you see here are some of the trends that all of you are already very familiar with. These are 6 big, what we call mega trends, some of which had already started at the time of the SDGs, but we weren't quite aware of the huge implications they were going to have for global health. But these are familiar to all of you, of course: climate change, as well as environmental degradation, human migration and displacement. We have 1 billion people displaced internally or externally to the countries in which they were born, the largest, unprecedented in human history. Zoonotic spillover events, we lived, all of us, through the pandemic. There are more to come, without a doubt, because of so many factors, some of which are on this slide. Geopolitical change, huge move, tectonic move. Plates are moving in the world of geopolitics, as you're aware, and realignments. Evolving science and technology, again, you're all living through this. Some of it good for health, some of it challenges for health, as we saw in the pandemic as well. And of course, the demographic shifts we are all living through. Not only, of course, aging populations and all the challenges and adjustments to the health challenges we have to deal with as a result, but also, of course, urbanization, other factors playing. So for all of these reasons, we decided to bring forward by a year. The Director General actually proposed to our member states, and it was the member states, the 194 countries of WHO or member states, that decided we needed to bring forward and develop a new, more robust strategy for this next period. Our strategy had been developed for the SDG period, obviously, but halfway through the SDGs, we're grossly off track, as you're well aware. We need a real shift to try and even directionally get in the right direction for the SDGs, and the current strategy needed to be updated for that purpose. So we've had a very intensive year. Again, many of you have been part of this. In May of last year, our Assembly decided we need a new strategy for global health, and then we kicked off what you can see, the timeline there, a very intense consultative process. By July, August, we already had the first draft of the high-level, let's say, mission statement, big strategic objectives for this next period, and we began the consultative process with each of our regional committees or the regional groupings of WHO over the next 6 months, but then also with much of civil society, youth groups, private sector associations, as well as our UN partners and global health partners. And you can see that led then to a total of five consultative documents, which evolved over the course of the year and now is the basis for what I'll walk you through. So it's been a very intensive year. And I want to highlight with the bottom of this, which we put in tiny font so you can't read anything, but I'll explain, this is who was part of that consultative process. So not only is the document quite different, but also the process is quite different, which we think is really important to the implementation and impact that this strategy might have. So what you can see in bright red there, which we always have to put at the top, is our member states. Intensive, more than 30 consultations with them. And I think we finally wore them out in going through this document. Over on the blue, that is the extensive consultation we had across the 3 levels of WHO to make sure our whole organization was part of it. On the right-hand side in the yellow, these are the different constituencies, civil society, private sector constituencies, youth groups, as I mentioned, foundations, philanthropic organizations, who we engaged multiple times to try and make sure we were anchoring the strategy in the right objectives, but also that we would take this forward together. And at the very bottom, you see our big implementing partners, Gavi, the Global Fund, CEPI Find, all of those, all of our UN partners, UNICEF, of course, FAO, WFP, et cetera, and then also the multilateral development banks who play such a big role. So everyone had, let's say, a kick at the can as we went along. Now, this is the big picture, what the strategy looks like. On the left-hand side, this is the document that the member states are going to look at on Tuesday afternoon, I believe. I've got to get the time right because I have to be there. And on the right-hand side, you can see sort of the big picture. There's 4 parts to this strategic plan. The first 2 are really about the global situation and the global ambition. And the second 2 parts are about what WHO will contribute and how we will, during this period, try and enhance WHO, the way we work, so that we can play a much better role in supporting the rest of you in this ambition. So as you can see, the first part is basically where are we in terms of the mega trends I just talked about and the impact and implications they're having for global health. And I'll show you a snapshot of that in a moment. The second part is what does that mean in terms of a global strategy? Linda, thanks for yawning. Either you just got off a plane or I really have to speed up. It's also great to have Linda in the audience to keep you anchored. And then when we get into the second, this is where you yawn. It's part part 3 where you're Jan, when we get into what we're doing to WHO. Right. So part 3 and part 4, as I mentioned, all about how we really get WHO focused on its unique added value. Not its added value. There's all kinds of things we can do which we think add value, but uniquely as a huge multilateral organization with 194 member states, a presence in 150 countries, a great convening power. How do you really leverage that? And then finally, how do we improve our performance? So this next slide, this is part of the context you'll find in the first part of the document. And this is what's alarming. You're looking on the left-hand side at healthy life expectancy. The red line is women, females. The blue line is males. And as you can see, 2 big things. First, the rate of improvement, which we saw during the MDG era, which was pretty rapid as a result of the real progress made on child mortality, immunization, many other elements, has really started to slow down. If you look at the dotted line, that's basically as you get into the SDG era. So all the gains in healthy life expectancy started to drop off, the fast progress we were making. And in addition, those lines between male and female healthy life expectancy weren't narrowing, which means we weren't tackling and able to address some of those big drivers. This should be an alarm bell for all of us because a big missed opportunity. And then when we talk about the Sustainable Development Goals, if we look at Sustainable Development Goal 3, right, 3.8, universal health coverage, 4.5 billion people lack access to the most basic services, whether non-communicable disease, communicable disease, et cetera. I see lots of people taking pictures of the slides. The slides are for sale. They're really relatively cheap, but it's all in a good cause. The WHO investment round that Daniel's going to talk about later. Yeah, take your pictures. So there's NCDs, communicable disease, et cetera. But basically, that basic package, half the world's population, right, can't access these. And what's really alarming, and you'll see more and more attention to this in this strategic plan, 2 billion people, a quarter of the world's population, are suffering financial hardship, often catastrophic costs, by trying to access life-saving health services. This should be completely unacceptable to all of us, and this is a very fixable problem, as so many countries have proven during this period. So while there's been a lot of let's say, less than great news in the SDG period so far, there's also been some very good news. 30% of countries during this same period, countries for which we have data, made progress on both of these indicators. So if the political will is there, and then the systems, the lined up partnerships behind it, you can achieve these things. So the next 4 years, as you see at the bottom, this is the unique window. It's the only window we'll have to try and reinvigorate these basics and, of course, future-proof our systems for the future. So what does the strategy look like? This is the strategy, let's say, on a page. First, the big mission statement of WHO, to promote, provide, protect health and well-being for everyone everywhere, the big equity statement at the end of it. And it's not just health, of course, it's well-being as well, bringing the mental health, the social health dimensions as well. Anchoring this, the mission are 6 big strategic objectives that roughly align on the left with the promote, the middle with the provide, and on the right the protect agendas. And these speak to the issues all of you so familiar with: climate change and health, the determinants of health, which really are the big drivers and which we're really going to lift up, advancing the PHC approach and essential service packages. And then, as you can see in the middle, improving not just service coverage, but also financial protection. If people with chronic diseases have got to pay, vulnerable people, for their medicines, frankly, they are not protected. It's as simple as that. And then, of course, the prevention and response agendas, which Professor has just been talking about and asking in the previous section. Underpinning all of these big 6 strategic objectives that are broadly agreed now by our member states, our partners, et cetera, and so much of civil society and others who played a huge role in this, are then what's WHO's contribution? And here we've really tried to sharpen this to what can WHO do almost uniquely in some ways as a multilateral organization in health and leading on health. So first, the health leadership dimension that we're responsible and accountable for. And what that means is the convenings around the health agenda and setting the health agenda, agenda, the research agenda, et cetera, facilitating the partnerships, the communications that are crucial to underpin all of this work, enhancing our normative work, the normative and technical support and guidance products that we develop as an organization, and also our tailored cooperation to our 194 member states to help take this agenda forward with our partners. So that's what the big strategy looks like, let's say, at a glance. Now, for each one of the strategic objectives, so this is, let's call it the promote agenda, there are 5 outcomes. We won't go through those in detail. And then under providing health, another, in this case, 6 outcomes. And then finally, in the area of protecting health and emergencies, 4 outcomes. These outcomes, these 15 outcomes, are called joint outcomes in the strategy, which means they're led by the member states. It's their agenda, their strategies, with the support of us, the Secretariat, WHO, but also all the partners and so many of the groups represented in the audience here today. So these are our joint objectives. The other 3, which I showed you at the bottom of the strategic objectives, we call those the corporate objectives. That's what WHO is accountable to lead on. And you can see right at the very bottom of this, achieving these joint objectives is going to require an extraordinary focus on equity. Are we achieving equity? Is that the lens that we're looking at with everything we're doing? Resilience of the systems as we go forward, and of course, intersectoral action. Something we've not been great at, quite frankly, in the health sector, but something we have to see a huge step on, up on as we go forward to tackle climate, to tackle determinants, even to tackle the emergencies and provision of health agendas. Of course, a strategy is great on paper, but you got to be able to measure results and hold ourselves collectively accountable to those. So in parallel with the development of the strategy, the big objectives, the big outcomes, we've been working with the member states, a very intense consultation. That's the document. It's 60, 70 pages of denseness that has been used to try and get alignment on the appendix to the GPW, which lays out for each one of the big outcomes we talked about, what are the indicators we'll use to hold ourselves collectively accountable, the joint indicators, and how do we recalibrate these triple billion targets we had in our last GPW to the world and this period looking forward. So that's the appendix. So those are the big elements of the strategic plan. The context we're working in, the big strategic objectives and outcomes we're gunning for, the role of WHO, and how we'll hold ourselves accountable. We can't do this, of course, without the funding. I'm not allowed to stand on a stage anymore without talking about funding WHO, especially when Daniel's in the audience and will speak later. But actually, this is a super important part of the GPW. As we saw most crucially in the pandemic, if we don't have a fully, sustainably, flexibly, predictably financed WHO, it is extremely difficult to take forward a coherent and coordinated global health agenda. This is the responsibility of this organization. $11 billion over 4 years is a lot of money, especially in a tight fiscal environment, but it's an extremely good buy. And that's what we're going to launch this afternoon, the WHO investment case, which lays out what a great buy that is, because that will lay out the investment round target for later this year, which is $7 billion. The difference between 7 and 11, by the way, is the assessed contributions of WHO, the dues that our member states paid to be part of this great organization and help take it forward. So that's our investment round target. This is going to be crucial to the agenda we talked about. So that'll seek to raise the funds above, or for that part of the GPW 14 envelope that is not covered by the assessed contributions of WHO. So last slide. In summary, so this new global health strategy, everyone says, well, what's new compared to the old one? So here's 5 big points, probably summarize that. First, it's all about trying to set a global health agenda. Many people have spoken to the point that this has been the most extensive and intensive consultation process across a very broad group of actors to try, most importantly with a strategy, to align the world on what's important in this next period for health and well-being. And if you compare GPW 13 to GPW 14, the first word in GPW 13 is, did anyone actually read it? says WHO, and then the first word of the next paragraph says WHO, et cetera. This one says the world, and it takes that bigger view. That was really important for GPW 13 because we were trying to reset the organization, but now we're trying to really leverage that reset to take the global health agenda forward. The second bullet, as we talked about, the big 6 strategic objectives that tries to say, here's what's important and where we have to move the needle in this next period. Really important in those strategic objectives is we've lifted up the essential health systems capacities, the workforce, financing issues, and we've lifted up financial protection. You can't have universal health coverage without it, quite frankly. And then, of course, recognizing, putting at the center of this, the criticality of partnerships. WHO is a big space to help with convene. It is a small space when it comes to moving an agenda like this. Our job is to help everyone else, the rest of you, do your jobs in supporting countries, communities to take forward this agenda. The new corporate outcomes sharpen up what WHO's value add is, and linked to all of this, right at the back end of the document, you'll see, and represented on the right-hand side, there's a section about our commitment to now take forward at our country level a more core, predictable country presence that makes sure we can support the member states in real time the way that they need to be to take this big agenda forward. So, after the Assembly, fingers crossed that the Assembly actually says, yes, we're still with you on this strategy. This is our strategy. I think they will. We had a good program budget meeting last week where we talked about this. Then the GPW gets operationalized for WHO through what's called our budget, our program budget process, which we kick off immediately thereafter and start going to our assemblies in our regional assemblies in August. So, ladies and gentlemen, thank you very much for a chance to talk about the new global strategy. This is it in a, I was going to say nutshell, but it's a very big nutshell. It took me a while to get it out there. But this is a strategy. It's going to require everybody behind it, everyone's voices behind it. But what I'd really like to do, wrapping up, is just say thank you. So many people in this room gave us so much input over the last 10 months in developing it. That was invaluable. It's the reason it's very much your strategy. And as you go forward, I hope, and I should have said it at the very beginning, you all have friends like the UN Foundation, because I didn't get a chance just to thank you for hosting us today. But with the UN Foundation, folks, I hope all of you have got friends as good as that, because that's the kind of friends help you get an agenda like this forward. So, any questions? There's no questions, no hands. Great. Thank you very much.
Thank you so much. My name is Serena Cruz, and I'm with an organization called the Global Surgery Umbrella.
Right.
And I'm really appreciating the way you broke this down for us. You did it in a very effective, thank you, a very effective period of time. So just to reintroduce, I'm Serena Cruz, and I'm with an organization called the Global Surgery Umbrella. I wanted to sort of do like a thought.
And before you ask your question,
Yeah.
I want to thank all the different surgery groups that harassed us throughout the 10 months
And
to make
oxygen,
sure that was
and
in there.
anesthesiologists and gynecologists, yes.
Absolutely.
So just think me through this. So we know that we've had an oxygen resolution, and last year we had the integrating emergency critical peri and operative care resolutions. Yep. What's the process then? So take us through a state, right? So that's a joint outcome. We've all agreed behind access to medical oxygen, access to echo care, and then what happens next under this new frame? What's the next step, and do we propose national strategic plans? How does it work?
Yeah.
Thanks.
Thanks so much, Marina, for the question. So what happens then, and we're going to go in now to a section in the Assembly, there's actually going to be a follow-up resolution, as you may, on the emergency operative critical care, which is all about now translating this into national plans and into work plans. So it depends a little bit on the resolution and how our member states want to do this. But generally, when they pass a strategy, they will then direct us in terms of a time frame for consulting through regions and with member states on how this gets translated into national plans, how that thing gets translated into a set of indicators. And this is what we just did this year on IPC, for example. And then, as we look at our program budget process, how do we build that in and make sure that we in the Secretariat have enough enough of a footprint to be able to manage that process as we take it forward. What we will do then is work with the member states, work with the partners on taking the plan forward. But you're absolutely right. The strategy is just a strategy, right? This is the big picture. This is aligning the world on an ambition. But then you got to have a system that takes that forward.
Okay, thanks.
Any other questions? Promise I won't bite. Ahmed, are we behind time? I'm off the stage. Is that what that means? All right, well, thank you all very much for a chance to present.
Bruce, I was just stretching my neck there. Yeah, now we'll move on to the next session, and that was, I think, a very good discussion on the GPW, and we are looking forward to that also being passed during this assembly. But I'd like to call on, sorry, you introduce the panel so that I speak less. I know you speak much less than I do, so we'll save a few minutes there. Please.
Thank you very much, Ahmed. I'm not sure if I speak less than you do, but I'll try my best to do that because we are indeed a bit behind schedule. First, I just want to take the opportunity. It's my first time taking the floor today. I'm Suri Moon. I lead the Global Health Center here at the Geneva Graduate Institute. I just wanted to welcome you all, to thank you all for joining, to say good morning, good afternoon, good evening, and to really express my appreciation to our colleagues at the UN Foundation with whom we've partnered for 10 years now on this briefing. It is my pleasure to open the discussion on, indeed, one of the themes that you just heard Bruce flagging is an important part of the context for GPW 14, which is geopolitics. And it's not the first time you've heard this word today. It has been raised already by a number of speakers. And what we will try to do in the next roughly 20 minutes together is indeed to explore the implications that these rising geopolitical divides have for global public health, for WHO, by exploring it through two specific themes, gender and war and armed conflict. So it is my great pleasure to welcome to the stage, in fact, our three speakers. First, we have Dr. Pascal Auditorium, who, as you can see, directs the WHO Department of Sexual and Reproductive Health and Research, as well as the Special Program Research Development and Training in Human Reproduction. She has a very long and storied career in global public health, including as an academic, formerly the head of the United Nations University Institute for Global Health before coming back to WHO in Geneva. Next, we have Anna Coates, who is with the Office of the Director General of WHO, as you can see here. She leads she's the unit head for the gender, please. Dr. Anna Coates also has a long and storied background, including in civil society, in academia, in the intergovernmental system at UN Women, for example, before having joined WHO, but a lifelong commitment to working on gender. Last but not least, we have Dr. Anders Nordstrom, as usual, three doctors in global health. As you can see, former ambassador for global health at the Swedish Ministry of Foreign Affairs, and I believe currently advocate and activist in addition to being a former ambassador, and has been working in particular on Ukraine and has been an observer, I think, a frontline observer in recent months to a number of the key developments on war and conflict and WHO's role in that conflict, in those conflicts, I should say. I'm going to come and take a seat, excuse me, so we can get into fireside chat mode. Rather than lectern mode. Okay, here we go. Thank you very much. As I flagged earlier, we will be exploring, indeed, the implications of the geopolitical divide through these two lenses. Some people have hoped or believed that health could remain immune from geopolitics, and certainly health as a universal value, as sometimes a highly technical subject, can be quite resilient, in fact, to geopolitical divides. I think we've seen that over the last few years. But we also know, everyone in this room and online, I think we know health is also highly political, partly because it matters so much, because it is really fundamental to every single person, as we were reminded of over and over again during the pandemic. So what I'd like to do, indeed, is to begin how geopolitics will shape the work of WHO, will shape our collective efforts, indeed, to achieve GPW 13. I'm going to begin, Pascal, with you, and ask you, to what extent have you seen gender become a proxy for geopolitical competition, and what are the implications of that for your work?
Sorry, first of all, I want to apologize for my voice. I've got laryngitis, and so I've written everything just in case I couldn't talk, but I never give up an opportunity to talk. And I also want to send a note to myself, never follow Bruce, who's one of my bosses, on a podium. Okay, so we don't have much time. Now, for years, decades, centuries even, gender equality, women's rights, sexual and reproductive health and reproductive rights, fundamental to bodily autonomy, to women's health and well-being, to survival, have been contested and in some countries criminalized. The contentions play out through national laws and differ from country to country. No one's arguing about that. And worth noting, also differ in some countries between their local practice and their international rhetoric. So already there are some tensions there. But as a world community, we came together and agreed through a whole range of conventions, declarations, pledges, agreements, commitments, development goals, that as a matter of equity and justice, and more instrumentally for economic and development and advancement, we needed to course correct and to provide opportunities that would recognize and redress the inequities and power imbalance associated with gender and a broad range of intersecting vulnerabilities and marginalizing factors. And who knew? There's been some progress, but with issues of equity, progress does require self-reflection about the notions of power and privilege, giving a little, sharing a little. So it stands to reason that various actors, less comfortable with changing the traditional ways, leverage these issues and their power to advance alternative political, economic, and ideological agendas. The promotion of gender equality and comprehensive sexual and reproductive health policies is perceived by many countries in the global south, mine included, I'm from Ghana, as cultural imperialism, leading to resistance and the assertion of traditional values as a form of sovereignty and identity. International organizations sometimes tie foreign aid to the implementation of gender equality and sexual and reproductive health policies. This serves to reinforce the friction with the recipient countries that assert different cultural and religious views on these issues. Gender equality and sexual and reproductive health and rights are increasingly framed within the broader context of human rights. Countries advocating for these rights may face pushback from those who view these concepts as contrary to their national values or legal frameworks. And the use of international human rights mechanisms to hold countries accountable to gender and SRHR violations further fuel these political frictions. Now, why now? The global rise of populist and nationalist movements often includes a backlash against gender equality and sexual and reproductive health and rights, using these as divisive wedge issues and threats to traditional values and national identity. Countries often form alliances based on shared values regarding gender and SRHR, influencing regional politics and international relations. Gender and SRHR issues are deeply intertwined with geopolitical dynamics, influencing and being influenced by global power structures, cultural narratives, and ideological conflicts. As these issues continue to gain prominence in international discourse, they will likely remain critical points of contention and negotiation in geopolitical arenas. Now, what this means specifically for our work, the imposition of restrictive SRHR policies that affect access to safe, comprehensive abortion care, for instance. Increased exposure to sexual and gender-based violence, access to contraception, and comprehensive sexual education are always on the agenda. The entrenchment of more restrictive laws as forms of resistance is often a reaction. Funding fluctuations. We always have to talk about funding. It's the investment route. But when donor countries and funders impose restrictions, it severely impacts the availability of sexual and reproductive health and rights services in affected countries. And inconsistent funding disrupts ongoing initiatives, limits the reach of services, and creates uncertainty for organizations reliant on the funding. Clinics close, services become more expensive, and the quality of care deteriorates. Legal and social barriers are created to accessing services. Stigma and discrimination, restrictions to SRHR services lead to adverse health outcomes, and so on. My throat is going to kill me, so I will stop there. But it's really important that as you again go through the next week or so, that when these ideas are raised, it is not always as was evident in the first panel. It's not always just specifically the issues, but it is the opportunity for these issues to disrupt the processes that we have all agreed together as member states to respect. Thank you.
Thank you, Pascal, for, despite challenges with your voice, really a passionate defense and reminder, indeed, of the implications of the ongoing, what I would call weaponization, actually, of gender in broader political contests. I'd like to turn, Anna, now to you. We've heard, indeed, how what were previously well-established norms at the international level are being challenged in ways that might be surprising. I'd like to hear from you what's at stake beyond health. What is it that WHO should do to respond, and what is it that many of us in the room or beyond should do to respond?
Thank you, and thanks for the question. I think framing it in that way in terms of the international norms that we accept, or we have long accepted, I think that's a really good entry point to thinking about some of the issues that Pascal was just raising in the geopolitical context about what is at stake. Thanks to Pascal, despite the challenges for setting up that context. I think it's a really hard discussion to have at the moment from somebody who's come from their entire career working on gender equality. Our common aim of gender equality, we have accepted it as being a given over many, many years. And it's currently being questioned in a way that's taking people really by surprise, although it shouldn't, because there has been a very coordinated effort from many different parties over the last few years. And we are seeing that very concretely in what's happening around the member state negotiations in WHA. But WHA is only one example. It's also happening in many other multilateral spaces as well. When you listen to the discussions in WHA and the somewhat sometimes painful wordsmithing that can happen, you may be under the impression that the polarization is about the use of specific terms. But we'd be wrong to think this is just about language. There's a really much more fundamental questioning that's happening about the underlying principle of gender equality as a shared value. And we hear a lot now of the use of the term gender ideology. And that's really what is at the heart of references to gender ideology. It's this idea that gender is just about imposed concepts. But gender isn't just about imposed concepts or about concepts at all, indeed. It's really just a shorthand to explain as a framework for understanding the realities of people's lives. The ways in which a lack of power and agency restricts people's capacities and opportunities in unjust and really often devastating ways, as Pascal was just explaining. And that's what's at stake. It's not just a discussion over words. Arguably, the WHO and the rest of the UN system has also made this too much about words over the last few years, over the last couple of decades even. We've had a lot of rhetoric around gender equality. A lot of it is a lot of language that has been included in a lot of normative frameworks around gender equality, but that has not always been matched by enough effort to generate evidence and enough investment in actions that demonstrate how gender equality can shift realities. It was mentioned right at the beginning today that very often resolutions are negotiated long before WHA. That's not the case right now. Negotiations are still ongoing. And what we're finding is that the reference to international norms is now not enough in the current climate. When we're in these negotiations, what we're very often asked is to supply evidence to support our advocacy. But then we're backed into a corner, really, because we don't have this the systematic gender data that we need in many areas of health because of the lack of investment. And we really desperately need to change that. I'm really happy to say the WHO just adopted the Sex and Gender Equity in Research Guidelines. And if we fully implement those and other initiatives, that will be a really transformative response to help us stress the importance of gender equality. We also need to recognise that evidence comes in a lot of different forms. We need to engage much more with civil society. We need to listen to different diverse voices at global, regional and national levels. We hear the most powerful voices in WHA, but there are also unequal power dynamics, not only between countries, but also within countries. The DG has established the Civil Society Commission at global level, and hopefully that's a chart for similar engagement at all levels. But there are also challenges with civil society at the moment as well. The women's movement is fragmented in a way that it has never been before over issues of sex and gender. And that's really unfortunately aligning with conservative movements' efforts to undermine our efforts towards gender equality. We have managed really to coalesce diverse interests around a united agenda since the Beijing Platform for Action, and we need to reinvigorate that shared agenda. We need to leave aside identity politics. In GPW 13, equity, gender and rights were prioritised as part of the Leave No One Behind agenda, but they were primarily envisaged as enablers of health outcomes. So in other words, gender equality is instrumentalised as a means to another end. That is really important. Of course, gender equality is important to achieving health for all, but it's also important to articulate that gender equality is an end in itself, and that health can play a really important role in driving gender equality, and that is crucial if we want to protect and preserve gender equality as a common value. In GPW 14, that we've just heard all about, advancing gender equality in and through health is articulated as a result directly related to primary health care. And I think that's a really hopeful signal that we will be transformative in the sense of WHO committing to working towards gender equality as a common shared international norm.
Thank you very much, and also for inspiring our audience, but also for reminding us why some of these sometimes seemingly minute debates in Geneva actually do matter for people's lived realities on the ground. I want to turn now from gender to think about war. Of course, the two are also related, but my colleagues here at the Graduate Institute have begun talking about how do we avoid the Third World War? How do we avoid nuclear war? Questions that, again, seemed unthinkable just a few years ago, now back on the table. And, of course, WHO's role, as we have seen ferocious wars break out over the last few years, WHO's role may also be changing or affected by this. We, I think, are all very familiar with WHO's traditional role as a normative, technical provider of guidelines, WHO's leadership role as a moral voice, as a defender of certain rights and norms. but also WHO increasingly being an operational actor, delivering humanitarian aid in armed conflict. And I'm wondering, Anders, because you have seen WHO from many, many different angles over many years, including having been about 20 years ago now acting Director General. What broader conclusions can we draw from looking at the role that WHO is playing in armed conflict about the challenges that geopolitics poses to the achievement of health, the achievement of GPW 14, and in the longer run, the role of WHO?
No, thank you very much. If I may just give one perspective on the gender issue, but from a war perspective. I was doing some, not very much, but smaller piece of work in Ukraine now some months back, working with the country offices, the next country strategy. What I learned in Ukraine is that life expectancy between men and women is 10 years. Men are dying 10 years earlier than women. Because of this, Ukraine, in normal cases, would lose 4% of GDP. Why is this? This is because we men are more stupid than you women. Drinking more, smoking more violence in between ourselves, not in the war, but just in the normal life. But most importantly, men are not seeking health care. We don't feel comfortable going for screening. All of this will, of course, be aggravated because of the war. I mean, the mental health of men coming out of the war will be even worse. This might be a different entry point also to speak about gender. That might attract some people to feel more comfortable that this is also part of our gender agenda. And what we see happening in Ukraine now, that needs to be at the focus. Because this is leading then, of course, to the big risk factors that leads to the great burden of NCDs, which is really the thing that is killing people in Ukraine right now, if you look at total number of people dying. To answer your question then in terms of the geopolitics and WHO's role when it comes to situation of war, of course what we see happening in Ukraine or what we see happening in Gaza now, what we see also happening in Yemen, in many other places of the world, it's horrible. I mean, people's lives are no value any longer. The attack of health workers, the attack of health centers is used deliberately as means in terms of the war strategy. I mean, we have passed many boundaries now. So I must say, to start with, because I'm going to also be a bit critical in terms of where I see WHO moving, but the way that Tedros has now, the Director General, has articulated and being very clear about the situation in Gaza, I admire a lot. I think he has had the integrity, standing up, telling people this is what is happening. And I think that is a role that WHO should continue to play. Where I have some concerns is that when I read the GPW, which I've done, and I think it's a very good piece of work, it's a very balanced approach with the 3 areas, the 6 main objectives. But when it comes to emergency, there is then also what Bruce said here. The main role of WHO is the normative technical one. When I was in another emergency during the Ebola outbreak in Sierra Leone, I was heading the country office. We had 440 staff, all doing technical work, hand-holding the ministry when it comes to epidemiology, surveillance, the Ebola treatment centers. But we did not procure one ampulla of vaccine. We did not provide any cold chain equipment. We did not provide any ambulances. That UNICEF did. So we had a division of labor that worked very well. So all the technical people, all the operational capacity we had was on the technical normative side, not providing supplies or vehicles or infrastructure. This is my worry, because if this is going to be implemented, which I think it should, WHO's leadership needs to take this serious. Because what I'm seeing, what I'm hearing is that there is an appetite to move into another area of work, which is basically to provide the supplies, the goods, something that is politically more attractive to be able to tell, which I heard the Director General doing at the last EB, how many ambulances we have provided. When I see at social media what WHO is doing is how many tons of supplies we have been providing, or you have been providing, it's no longer me. And that's a worry to me, because I don't think neither WHO is equipped. WHO do not have the systems to procure. WHO do not have the systems to manage financial resources, to implementing partners, which UNICEF and UNFPA has. WHO hasn't got that, I know from inside. And that's a worry that WHO is moving in this direction. If I look at the last, not this program budget, but the last program budget, 2022-23, 46% of the actual expenditure was spent on emergencies. So here we speak about the base budget, but remember that there is a big budget outside there, $1 billion, that year became 2.8 billion, 1.8 spent. So that is, of course, WHO's work, and that is distorting. And for me, that is also distorting and diluting the quality of the technical work of WHO. So that's a big worry. And the big question for me is now, if we're moving in this direction, and this was something we were discussing when I was heading the Secretariat for the independent panel, should WHO actually be split into two? Should the same thing happen to WHO that happened to FAO in the 60s, when WFP was created? So will this happen that we will have a World Health Program doing that operational work? I don't think that is needed, because I think there are other parties in the system that could do that and can do it better than WHO. And my very strong view in situation of emergency, do what Tedros does in Gaza. Make the world aware. Make sure that we have the data, the evidence, the technical advice, like what I did in Sierra Leone, but don't go into the very attractive trap here of saying that how many ambulances WHO has delivered. Thank you.
Thanks, Anders. As usual, not mincing your words. We could certainly continue exploring this theme for much, much longer, but a number of you have mentioned financing, and we have an entire really important discussion to have on financing that is still on the program. So I'm going to use the moderator's prerogative, in fact, to end our panel here. Thank you so much. I think the challenge is indeed to international norms and the fundamental questions around how can WHO remain trusted as a moral leader, as a technical actor, as a normative voice in an increasingly polarized world is something that we will certainly see. We'll struggle with this throughout the week and certainly in the years to come. So please join me in thanking our speakers, and we'll turn now to the next panel.
Okay, thanks everyone. I'm Lori Sloat. I work with the UN Foundation and just wanted to thank, again, our co-hosts with the Geneva Graduate Institute. It's been a great partnership for 10 years. And really, this is all about trying to getting the hot issues of what's happening in the Health Assembly here in Florida to discuss it a little more informally than we're going to hear throughout the week. So just really appreciate the conversations in the previous panel. So thanks. And I can tell we're getting a little heated, and nothing is going to heat us up more than financing and health, because financing is definitely a heated subject. So just really quickly, because I know we are a little behind schedule, just to kind of, before I introduce my panelists, just to say there's a lot happening, obviously, in the financing for health, for global health. You have, in terms of multilateralism, questioning how do we actually make multilateralism effective, but to give it the financing that it needs. So we'll hear a lot about, from the WHO perspective, of what this looks like in the investment round that they're proposing. And within the multilateralism, it's really important to have national governments also being able to drive their own agendas for their global health challenges that they're facing domestically. And so how can we leverage better ways to do that? So we'll also hear from an initiative about the Future for Global Health initiatives and what's now known as the Lusaka Agenda. So really looking forward to the discussions, and I'd like to introduce my panel now. So first, we'll start with Daniel Thornton. So he's, come on up to the stage, Daniel. He's now the director for what's called the Coordinated Resource Mobilization at WHO. Some of you in the audience may know Daniel from his previous role with Gavi, the Vaccine Alliance, where he also worked with financing as a director for that body. And then next, I'd like to call up Desta Luku. She's from AMREF Health Africa, and she has been a co-chair for what was the Future for Global Health Initiatives, and is now working with the Lusaka Agenda Working Group as well. And finally, Bjorn Kummel. He's working with the German government, and Bjorn's a bit of a rock star. Some of you might know him in the global health world of being responsible as the co-chair for the Sustainable Financing Working Group several years ago, which has led us to have the assessed contributions for WHO now geared towards 50% of its budget by 2030. So we'll get into that in a little bit, but just wanted to welcome them, and please give them a round of applause as we get started. Thank you. Okay, so Daniel, I'm going to turn it over to you first, because it's obviously this week is the Health Assembly, and so, you know, given all of what's happening in sort of the financing ecosphere, the ecosystem, heart and part of it is the global mandate of WHO to sort of get us to that in terms of the role we saw, the general program of work, and obviously the financing that's needed for that. So, but just since we're talking about geopolitics and the increasingly polarized world, just curious to hear from your perspective how you see WHO in that.
Thanks very much, Laurie. It's great to be here. My first time at the Graduate Institute, and I'm 3 months into my role at WHO, so I'm speaking with a certain humility today. It's great to see so many people here with the Walk the Talk T-shirts on. Unlike Bruce, I just walked, so I can afford to leave my jacket on. I mean, I think when we have a polarized world, and you know, there are some really important geopolitical challenges that we face. But I also think it's important to keep some perspective on that. I mean, when WHO was started, the Soviet Union was part of it briefly, but then I think Stalin took the Soviet Union out, and the Soviet Union didn't rejoin until after he died. Smallpox was abolished in 1980, and at that time, or rather, the World Health Assembly up the road declared that smallpox had been eradicated, I should say, in 1980. And at that time, you know, the Cold War was really getting hot. Afghanistan had been invaded by the Soviet Union. There were lots of debates about nuclear weapons and being placed in Europe and so on. But it was still possible to make progress on global health in that environment. And I think that's important to remember as we think about the GPW14, snappily named GPW14, the strategy for global health that WHO is coordinating. It is possible to make progress in global health, even in the most difficult environment. And in fact, health is something that brings people and countries together, because we can all, we hope, agree on the basic needs that people have for health, the science behind it, and the progress we can make over the coming years. But of course, to make that progress, I'd like to congratulate the audience on the variety of their ringtones that we've heard today. As we make progress on global health, of course, we need to have some financing. WHO needs financing to do its work. And on that basis, I'm pleased to give you a sneak preview of a top secret document, which is the investment case. Anders was trying to wrestle this copy off me earlier, but I'm determined to keep it so I could give you that sneak preview. It's going to be launched on Tuesday, so after that it won't be top secret. But it sets out the case for investing in WHO so that we can fund the strategy for global health. I think, you know, WHO needs financing, and it needs it because it's providing global public goods. But those global public goods, those norms and standards, are not just sitting in a library here in Geneva. They're disseminated through 154 country offices, so that the WHO representative in that country sits next to the Minister of Health, and when that Minister of Health is producing a new law on sexual and reproductive health, let's say, they get advice from the WHO, and that's based on the latest norms and standards that WHO is producing. It's not a theoretical system. It's something that has a very practical impact, and it's hard to explain. I mean, we spent quite a long time working on this document, trying to capture the breadth of WHO's activity, but it is absolutely vital. And in terms of the emergency response, I mean, I think, you know, I spent a lot of the last few years working on the COVID pandemic, and clearly the response was not adequate, and we need to do much better next time. And you know, a large part of the funding that we're asking for the strategy is about being ready. And of course, we need, as the co-chairs were saying, we need new international agreements to make that happen. But we also need to finance the system that is providing the surveillance and providing the response to those outbreaks, which can lead to pandemics. So I hope that we will have support as we launch the investment round tonight. And as we launch the investment case on Tuesday, we have a big job to do, raising at least $7.1 billion for WHO.
Okay, thanks, Daniel. We're going to come back a little bit later with some comments from Bjorn on sort of the importance of the sustainable financing of WHO and maybe what some of the challenges are ahead of that. But so given that, Desta, with WHO and the importance of making sure that there's sustainable financing for, the global body mandated for health, but there's a bigger ecosphere happening here. And your role as, what some people may be familiar with what this is, but there's a Future for Global Health initiatives where there was a body that was launched the recommendations and the final conclusions in what is now known as the Lusaka Agenda, which actually lays out 5 strategic shifts that are needed in the near-term priorities around the global health initiatives, but also how that impacts the broader health ecosphere as well. And so maybe, Desta, if you could touch a little bit on sort of what is the progress of the working group and where it sits with the Lusaka Agenda now, and then we can also talk a little bit about, if you want, in your remarks, of how that would relate to WHO beyond the global health initiatives.
Sure. Thank you so much, Laurie. And I just was really excited that Precious was here earlier, and she mentioned feeling like a surrogate to this baby. And and it's only Africans that do that, right? Ahmed said that earlier as well, mentioned that. But in reality, we are like surrogates releasing this baby, because this is now, the Lusaka Agenda is the outcome of the FGHI process over the last, I think, 13 months. It's a very short-term, time-bound process. And so this body of work really, as you mentioned, alluded to earlier, focuses around 5 key shifts. And our job really is to ensure that those 5 key shifts carry a life of their own, because this is a very time-bound effort. It's currently run by 2 governments, Canada and Ghana, and an NGO, CSO, AMREF. So I'm one of 3 co-chairs. And we have really seen, and what the 5 shifts, it really captures, the work that we're doing really captures the 5 key shifts around the long-term evolution of global health financing systems. And we heard earlier that financing was really critical for global health, delivering UHC, et cetera. And the way we've sort of pushed this out is to use GHI's, Global Fund, Gavi, and Global Financing Facility as sort of entry points to deliver on the Lusaka Agenda. The agenda itself really calls for, a few key things. Number one, it's really for these GHIs to make a stronger contribution so that they can support strengthening of health systems. The second one is really around strengthening alignment towards financial and programmatic sustainability. There is a third sort of shift around, joint approaches for achieving equity and health outcomes. Equity was earlier mentioned by Bruce. He talked about equity, he talked about financing, et cetera. So really aligned with what WHO is doing. It talks about improving efficiencies and how do we reduce transaction costs for countries. The last time we had a convening with ministers of health in Africa, one of the key things was it's expensive. The transactions cost is high. The GHIs are asking for vertical sort of processes to get financing, which is really important. So how do we reduce that transaction cost for countries? And then the last shift was really around coordinating approaches around R&D and manufacturing. That hasn't yet really moved as far as we would like it to be. But the vision really is, how do we engage GHIs and other actors as well to really support countries in achieving domestic financing that is country-led. So the countries have to be on board to help us move closer to this. So we are, of course, pleased that UN Foundation is a partner on this as well. And we are now focused on two short-term objectives in this short period that we're aligned around. One is anchoring the Lusaka Agreement agenda on the agendas of Gavi, Global Fund, and Global Financing Facility, and the boards of the Africa Union as well, to drive implementation, or at least begin the implementation process, and then to engage other key stakeholders. So we've been doing quite a bit of that, bilateral funders as well as others, to advance the agenda shifts themselves and the priorities in the broader global health financing ecosystem. So we're seeing quite a bit of important progress towards these key shifts, and our goal is really how do we keep the threads running. The first really is that the boards of Gavi and Global Fund and GFF are now discussing the establishment of a joint committee working group, which is tremendous progress in 3 areas of joint work, and that's malaria, that's health system strengthening, and country engagement. In fact, Gavi and Global Fund are now collaborating on a 4th joint working stream, which is really around back office functions. So we're very encouraged by this energy and this new development as well. The second example I can give you is really, you heard Bruce talking, so need I say more? It's really around WHO that's facilitating partnerships so that we can develop some common metrics for health system strengthening and as well as for measuring. The third thing I can mention is that WHO Afro is actually convening member states and other key partners next month in Ethiopia for a technical meeting to just discuss how can we advance the Lusaka agenda further. And I think fourth, which in my view is fairly significant, is that the Africa Union decision to endorse by heads of state and government to support the accountability mechanism for the Lusaka agenda. So I think that is going to be a real game changer for countries and for advancing that Lusaka agenda as well.
Yeah, especially that last point's very exciting in terms of getting the ownership of countries to sort of influence how the financing is coming into countries, and then to ensure that it's going towards UHC and beyond sort of some vertical programs. It's all important, and so with that, I guess I just would reflect on how these are all linked. Is that it's a lot of people talk about financing and the need for more financing, and that's true. I'm sure there's more financing, but there's also ways to better leverage existing financing. So if you take a look at what the Lusaka agenda is addressing, it's my understanding is there's about $5 billion that it's going to Africa every year from the Global Fund and Gavi, right? So how do you take that money and ensure that countries can say, okay, maybe this is across a broader UHC spectrum, as an example. And similarly with WHO and its financing, what it's trying to do now, and this is what I'm going to ask you, Bjorn, is it's not really asking for more money per se, right? Like each biennium budget, if you looked at what Bruce presented before, is about $2.5 billion. So what's looking to do is, even in the 7.1 billion, right? The 7.1 billion, let me back up a little bit. What I'm trying to say here is that for the overall budget, for the 11.1 billion, there's the assessed contributions, which was what the work that Bjorn was doing, amazing. Really try to get the member states to agree to have the proportion of that budget be much more flexible through assessed contributions. And that was achieved. Last year, there was an approval of the 20% towards that trajectory, right? It's a phased approach to get the membership dues, which is flexible funding, by 2030, half of the budget to do that. It gives the organization more flexibility to spend that funding. But that still leaves 50% of the budget in 2030, best case scenario, will be voluntary contributions. And that money is highly earmarked. And so that's what the investment round is really trying to assess right now. Is like, how can we get more flexible funding from that 7.1 billion so that we can put it where it's needed in terms of the priorities? So Bjorn, that's my question. In terms of the assessed contributions and the voluntary contributions, what do you see as the hurdles from member state perspective of getting to more flexible funding overall, but particularly as the investment round's trying to address with the voluntary contributions?
Okay, first of all, thanks a lot for having me here. It's a great pleasure to be back again. I think
I've been here a couple of times. And the issue of sustainable financing for WHO is still on. It's an ongoing journey. As you mentioned, I think we achieved some successes already in the working group, but there's more to be expected. Today or this afternoon will be a key event, the launch of the investment round. And then obviously, I guess everybody knows that the investment round will happen in the last quarter this year. So that's going to be very, very exciting. And the idea of the investment round is to cover, well, one part of the budget, which is the voluntary component of the base segment. And the idea is to really lobby on the highest political level, presidents and prime ministers, for adequate funding for WHO, not only flexible, I think that's also important to realize, but also predictable funding. We often focus too much, fairly enough, on the flexibility of the funding, because obviously one of the key challenges for WHO is that most of the funding comes in very, very earmarked. So WHO cannot do and use the funding as it wants, but rather, obviously, there's a contract in between WHO and the donors, and WHO can only use the funding as foreseen in that contract to be negotiated in between donors and WHO. But the other big component and challenge is the predictability. I'm not sure how many people work for WHO here in this room, but if there were, I don't know, 50, I guess 40 of them would not have a continuing appointment, but would rather have a contract maybe for a year, maybe for 3 months. Many would work as consultants, etc. And that is due to the way we are financing WHO, through unpredictable resources. WHO has to run after donors basically every day. The assembly is one of the big, I think, assemblies where we will see WHO technical colleagues approaching donors in order to raising funds for the future. And in order to avoid that, and rather to streamline that, put that on a rather stable, transparent footing, the investment round is the idea. We'll see whether it works. This is one of the outcomes of the IPPPR recommendations and the working group on sustainable financing, one component. I think one key idea, what we're trying to achieve through the investment round, we should also mention that quite clearly. The world is changing, geopolitics are changing, but it's interesting to see who is actually funding WHO. It's been, over the past 50 years, the same 18 key donors, and that will not be sustainable for the future. So we will have to broaden the donor base, and basically everyone who can contribute from the 194 member states needs to contribute. And for that, I think, apart from the assessed contributions, the investment round is a key driving force for that, and we will see whether beyond the traditional donors, others will step up. It's a great challenge, because I understand that from each of the 6 WHO regions, there are co-hosts who are trying to do their utmost to lobby for more funding coming in. But the last point I'd like to mention is, apart from the voluntary contributions, which are obviously key to be raised in a sustainable, predictable, and flexible manner, we still should not forget the assessed contributions. So it was a success that we were able to increase the assessed contributions by 20%, but this was not foreseen to be the last step. There are further steps to happen, but member states will have to again agree towards them. And I think there needs to be a strategy. And I think especially this group and much what we achieved in the working group was due to the enormous pressure and help and support from outside WHO, so from non-state actors and colleagues who are lobbying in favor of global health. So let's keep on lobbying for that.
Thanks, that's a great point. And so just to reflect on the last point there, just as Bruce had mentioned, the program budget, the general program is operationalized through the program budgets. So at each time that we negotiate the next program budget for 26-27, the member states come back to say, okay, we agree to this amount, to the next amount for the assessed contribution. So while there's a plan, there's not 100% guaranteed that they're going to commit in the future rounds of the program budget. So it is important to keep up the advocacy for both the assess contributions, but then also how do we make it more flexible and predictable for voluntary contributions. So I know that it was really great to have a great chat. I could chat with you hours about this, and I'm sorry that we don't have time for questions. It's really something we'll have to work on in next year's program, is to make sure there's much more interaction from you all. I'm really very apologetic towards that. But thank you all to all the panelists for everybody's comments. It's been a really great afternoon/early morning, and looking forward to this week's conversations. I'm going to hand it over to Sweri to close us out. Thank you, everyone.
Very much, Laurie, and to indeed all of our speakers who emphasize the role of funding. In closing our event today, I hope that we have offered you a view of the week ahead of some of the biggest issues that are on the agenda or likely to be on the agenda, and also a chance to reflect on some of the bigger picture trends and challenges and the stakes. For me, there's one takeaway theme that helps me to connect some of the different pieces that we've been covering today, and that is the importance of international norms and rules, how those are under challenge in a way that is unprecedented, the importance of defending widely held and long-held international rules and norms, for example, on the rights of women and girls, and also the importance of trying to negotiate new rules to try to make the international order more equitable than it has been, as we've heard, in efforts to amend the international health regulations and to develop the pandemic treaty. I think even more broadly than that, what is at stake this week and where WHO and the Health Assembly in particular is really a microcosm of what's happening more broadly is the question of a rules-based multilateral order. Are we satisfied to live in a world where might is right, where rules get ignored, where norms get broken or incinerated without any consequences, or do we want to continue pushing, indeed, for a world where norms and rights and international rules help to protect the health of not only those who are very powerful, but also those who are very vulnerable? So much at stake this week at the WHA and WHO. Please allow me to spend a couple more minutes just thanking everybody who has worked very, very hard to make this discussion happen today. I'd like to thank, first of all of our distinguished speakers for sharing your insights and your time in a very, very busy week for all of you. I would like to thank all of our participants online and in person, and I share indeed Laurie's regret that we did not have more time for interaction. We will certainly do our best to make that more central in the future. I'd like to thank all of our colleagues at the UN Foundation, Ahmed Agwal, Laurie Sloat, Camden Malone, John Lang, and Molly Moss, neither of whom are here in Geneva this week, but have been really critical in shaping this program. I want to thank my colleagues at the Global Health Center, Ellen Roscom, who's been leading this work on our side, Bettina Zago, Erika Scheinerberger, Thomas Moracevic, Moin Hossein-Alipur, and Tigoni Karkanaki. And at the Graduate Institute, our fantastic events teams, our communications teams, our IT teams who have made everything run seamlessly today, and our catering team, who have prepared for you a reception. I'm really delighted to invite you all now to join us upstairs in the cafeteria for a reception, a chance to say hello to old friends and new, and especially to welcome Dr. Ahmed Agwal Uma, the UN Foundation's new Vice President of Global Health Strategy and our long-term partner.